Hello friends, there is a patient with acute calculus cholecystitis, and this video demonstrates that robotic cholecystectomy can be done safely and very nicely in case of acute calculus cholecystitis. So here you can see that momentum is densely adhered with the gallbladder and gallbladder is hugely distended. So I have decided to puncture the gallbladder, and you can see the mucus is coming out. So it's a acute calculus cholecystitis with mucocele. Whenever there is gallbladder is over distended gallbladder with mucocele as a content, so that means there is an impacted stone at the neck of the gallbladder. So this patient had the same thing. So I just after decompressing the gallbladder, it becomes much more easier to hold the gallbladder with the tooth grasper. So here you can see after decompressing the gallbladder how thick the gallbladder is, and with a tooth grasper with the assistant port, the laparoscopic instrument, the fourth port, fourth 5 millimeter port I'm using for gallbladder retraction. And then three robotic 8 millimeter robotic ports were used, one with monopolar hook, you can see, which I'm using for omental adhesiolysis. Using monopolar energy in hook, and then left hand instrument using the fenestrated bipolar grasper. Had there been any requirement of bipolar cauterization, you can see I'm just trying to do it with bipolar energy. So momentum was densely adhered, you can see. Because of the inflammatory acute attack, the patient had multiple episodes of acute pain abdomen, and for which the inflammatory adhesions were there. So the target is to stay close to the gallbladder, hug the gallbladder, and release everything which is adhered with the gallbladder. So, but very cautiously, you have to go till the Hartmann's pouch is visible, and while going down, you may find that duodenum is also adhered. So while going down, you have to be very cautious. Sometimes duodenum is densely adhered, and during the process of adhesiolysis, duodenum may get injured. So you can see I'm just changing my grasper, changing my retraction downwards, and you can see the duodenum is also adhered. So just be cautiously, there is a large impacted stone at the neck of the gallbladder. As I said, whenever there is mucosal of the gallbladder, distended gallbladder, that means there is a impacted stone at the neck of the gallbladder. So duodenum is brought down, and then gradually holding the additions were just trying to release and not going down, just staying at the level of the Hartmann's. Sometimes because of the impacted stone, there is inflammation all around the neck of the gallbladder, and there is neovascularization. So sometimes it may bleed. You may find more than the usual number of blood vessels in and around the neck of the gallbladder. So you have to be cautious, and having a monopolar and bipolar energy in both hands, it becomes much more easier to control the bleeding in robotic surgery. So you can see just holding the gallbladder is sometimes difficult when there is impacted stone. I'm just trying to manipulate the gallbladder as much as possible so that I can see the anatomy all around the Hartmann's pouch. So staying above the after complete retraction of the gallbladder, staying above the Ruvia sulcus is the key. You should not go below the Ruvia sulcus of the key, and you can see I'm just doing the dissection at the junction of the Hartmann's pouch and the cystic duct, and not doing dissection below. So the idea is to do that dissection at the level of the gallbladder and cystic duct junction, and better not to see any CVD during the process of dissection. So we should not go down below. So very cautiously, I'm just trying to create a window between the gallbladder and the liver, and trying to do the dissection of the Calot's triangle. And you can see that I have created the window, and this is the cystic duct, and this is a short cystic duct, and maybe because of the impacted stone at the neck. So, and this is the cystic artery. So there are dense inflammatory adhesions in the Calot's triangle also. So I'm just seeing whether I can put 3 clips here. So once I'm sure that there is enough space to place 3 clips, I will place it. So cystic duct, cystic artery identified, and window created. So I'm just putting 3 hemolock clips. So 2 in the proximal towards the CVD, 1 towards the gallbladder, and then I will put clips for the cystic artery also. So you can see the articulating movement of the robotic instruments, tip of the robotic instrument, that helps in proper getting proper angulation to do the dissection and to put the clips. And wherever suturing is required, the suturing becomes much more easier with robotic surgery also. So now the assistant surgeon through that fourth port will bring the scissor. I'm just giving the retraction so that he can cut the cystic duct here. So my assistant surgeon is now helping me to cut the gallbladder and the cystic duct, and then again he will give that traction, and I will lift up the gallbladder from the liver bed. So in cases of acute gallbladder, acute cholecystitis, there is dense adhesion of the gallbladder with the liver bed, and you may find it difficult to find a plane between the two. And sometimes while trying to dissect the gallbladder completely of the liver, we end up injuring the liver parenchyma and ending up injuring the opening of the liver sinuses, and it may bleed. So try to dissect as much as possible. So if possible, the whole gallbladder should come out. But whenever you find that there is a dense adhesion of the gallbladder wall and the liver bed, better to leave a part of the gallbladder with the liver. And whenever you see there is undue bleeding is happening during the process of lifting of the gallbladder, leave a part of the rim of the gallbladder, posterior wall of the gallbladder. You can see there are bleeding. So maybe I am going into the liver bed. So just decided to leave a rim of the gallbladder, a thin rim of tissue, the posterior wall of the gallbladder on the liver bed, and will take out the rest of the gallbladder. So that is the safest way, and that in that way you can avoid the bleeding from the liver bed. And sometimes the bleeding from the liver bed is very difficult to control. You even know which liver can bleed torrentially, and then you may end up suturing or giving compression. So I have seen this kind of bleeding, and sometimes very difficult to control. So in acute cases in particular, whenever you find it difficult, you better leave a posterior leaf of the gallbladder. So now after that, like hemostasis should be achieved. So here you can see I'm just checking for the hemostasis. There is small bleeding from the posterior wall of the gallbladder and the liver bed, small oozing. So just cauterizing it, and the assistant surgeon is suctioning it. So just confirming whether everything is fine. So this patient did well in the postoperative period. He was mobilized within 4 hours and allowed diet and discharge on postoperative day 1, and patient had an uneventful recovery. So thank you so much for watching this video, and keep watching for more videos.